Okay, so thanks everyone for joining this number 8 in the RadNet City of London seminar series. Just to introduce myself for those of you who I haven't met yet, my name is Jamie Dean. I'm a new junior group leader in the RadNet City of London Centre, running a team working on computational radiation biology and oncology. And so the aim of this seminar series is really to initiate some connectivity and give insights into new areas of research in radiation biology and oncology, and lay the way for potential opportunities to collaborate and build expertise in different areas. So before I introduce our speaker today, just a few basic housekeeping points. So if everyone could make sure their microphones are muted and cameras turned off. And if you have any questions, please raise your hand and then you can ask them. Or if you'd rather not ask them in person, then feel free to drop them in the Q&A and I can ask them on your behalf. And then finally, just to note that the meeting will be recorded. Okay, so I'm delighted to introduce Dr. Nadeem Riaz to give our seminar series today. Nadeem did his medical training and bioinformatics training at Stanford University before completing his training in radiation oncology at the Memorial Sloan Kettering Cancer Center in New York. He's currently the director of their Precision Radiation Oncology initiative, and he's done a lot of highly prominent work in using computational approaches to predict response to various treatments, including DNA damaging agents and immunotherapies. And he's got an interest in the interaction between the DNA damage response and the response of the immune system. So as well as doing all that, he's also done a lot of very impressive clinical research, including some very exciting recent work on personalized approaches to de-escalating treatment for oropharyngeal tumors using a combination of imaging and genomics. So I'm really excited to hear what he's going to talk to us about today. So over to you, Nadeem.
So thank you for that really kind introduction, Jamie. So I'm just going to share my screen. Great. So today I thought I'd discuss our work on precision radiotherapy. I'm going to just start briefly with just some disclosures. These aren't going to be related to the work we discussed today. And as an outline of my presentation, I'm going to just give a little bit of a background or an introduction on what we mean by this idea of precision radiation oncology. I think there's some things we do very well in terms of making our treatments very precise, and there are, of course, a lot of area for rooms of improvement, but I think it helps to have sort of a unified definition so we're all on the same page. I'm going to then review two stories with you guys. The first one is the work Jamie just mentioned in oropharyngeal cancer, where we've worked on personalizing treatments for patients. And the second is using genetics directly to personalize treatment. And then I'm going to leave off with some thoughts about how we can move the field forward. So what do we mean by precision radiotherapy? I don't think any of us think we're practicing imprecise medicine or we're not personalizing our treatment, but I think it helps to have a clear definition. And so this is something I've come up with, but I don't think this is anything very fancy, but and if we had to summarize it in one sentence, I would say it's the right dose of radiation for the right patient, targeted to the right location with minimal toxicity and the correct radiosensitizer. Now, some of this I think we do actually very well, but some of it there's room for significant improvement. So why don't we break this down into its constituent parts? So the patient, how do we find the right patient? Well, right now, I think we're pretty good at identifying which patients need radiotherapy. It's often based on pathology information. For example, in the adjuvant setting or in the definitive setting, we often rely on histologic grading, like whether there's low-grade DCIS or Gleason 6 prostate cancer, or perhaps oncotype scores. And we can think about a future research program in this space because we know there are technologies developing that'll further allow us to help us refine the uses of at least adjuvant radiotherapy, such as the ability to detect minimal residual disease with things like circulating tumor DNA, or perhaps with refinements in molecular imaging and functional imaging-based techniques. How about the location or delivering radiation to the right location? Well, I think here we have to be very thankful for our physics colleagues for really remarkably improving cross-axial imaging over the past several decades. That's really led us to be able to refine our GTV delineations to make them more precise. And as we've become more comfortable treating patients in clinic, we've started optimizing our elective volume coverage. And I think there's also a very clear future direction for a research program that I think has relative broad consensus within the field, which is, of course, molecular and functional imaging will allow us to further refine these volumes going forward. How about for conformality or toxicity? Again, I think we have to thank our physics colleagues for really helping us develop technologies which can allow us now to deliver radiotherapy with millimeter precision. Today in clinic, we use IMRT, IGRT, spacers, gating, and tracking, all to more precisely deliver radiation. And again, I think there's good consensus on the field on how we can improve this going forward with further incremental advances such as protons or MR-Linac to further improve conformality and subsequently reduce toxicity. Now, how about giving the right dose to the patient? Well, what do we do today? Well, what we do today is actually maximum tolerated dose. And if you'd ask the field about how we should approach this in the future, I think you'd be hard pressed to find any consensus amongst a group of radiation oncologists or physician scientists or scientists in general on how we could move this forward. But are we even doing maximum tolerated dose today? We're not doing maximum tolerated dose either, because the doses we use in clinic today were developed in the 70s and 80s based on ancient technology where we blasted people's entire faces, as you guys know, with conventional techniques. So what we're doing is historical practice of radiation oncology. And we really haven't figured out a way how to personalize treatments for individual patients in clinic effectively today. How about identifying the correct radiosensitizer for a patient? Well, this is really based on large randomized studies that were conducted in the 90s, and it's relatively empirically based. Again, if you were to ask a group of physician scientists, or radiation oncologists on how we would move this to a more personalized regimen in the future, I think you'd be hard pressed to find any consensus. And so what I want to discuss today is this group right here on how we can personalize doses and how we need to start making progress to move the field forward. Now, our remarkable advances in physically delivering radiotherapy have really led us to sort of adopt mentally this sigmoidal uniform dose response hypothesis, where we often assume that if we are here on a dose response curve, if we increase the dose by 10 to 15%, we might have significant improvements in local control. Whereas if we sit here on a dose response curve, if we decrease the dose by 10%, we may wind up improving maintaining local control while minimizing morbidity. And while this mental model, I think, while these sigmoidal response curves are, of course, quite important when we're thinking about developing trials with physical improvements in dose response in our ability to deliver dose, they obviously have led to they've obviously led us to sort of neglect what we know exists, which is the significant heterogeneity and sensitivity to radiotherapy. So although these let us easily conceptualize trials that can take advantage of improvements in physical delivery, we know there's dramatic heterogeneity, and we know there are patients that are likely their dose response curve actually should be shifted all the way to the left, and some that should be shifted all the way to the right. And so how do we know this? Well, when we go back to older clinical data, this is data from Rod Withers looking at dose responses to tonsil cancer before there was sort of this consensus dose of giving 70 gray to everybody. And here you can see that there was a wide range of doses delivered to patients between 30 gray and 81 gray. And there was a wide range of fractionations delivered. And what you can see is that we don't what you can see is that we don't see this sigmoidal dose response curve. What we actually see is a very flat dose response curve, here shown for T3 and T2 tonsil tumors separately, again, indicating that there's quite a bit of heterogeneity within the individual patients that we're seeing. And so what we really think, of course, is happening in clinic based on that work from Rod Withers, based on some work from Michael Bauman and others, is of course that we know there's significant heterogeneity, and we know that there's some patients who are very resistant to radiation and some patients who are much more exquisitely sensitive to radiation. At a broad scale, we know when we at least think about cancers within individual broadly by histology, we know this is true. We know GBMs are quite radiation resistant, and we know lymphomas are quite radiation sensitive. Similarly, we might think lung cancer might be this curve and head and neck cancers might be this curve, but we've never made the further step forward, which is how about within an individual disease site? Even within an individual disease site, we know that there's going to be significant heterogeneity. Now, the big problem, of course, is we can say we know there's heterogeneity, but we need a way to really identify patients on which curve they belong to. And of course, if this heterogeneity exists, what we would expect to see is actually not a sigmoidal response curve, but the sort of much flatter curve, which is what we do in fact see when we looked at human response data across a broad range of doses. So I think the big question for the field is there a way for us to identify patients who are much more sensitive within histology? And can we personalize the treatment for those patients? And so I'm going to discuss with you two stories. The first story is an HPV-related head and neck cancer, where we postulated that there would be a subset of patients that would be exquisitely sensitive to chemoradiotherapy and that would be able to receive a 60% reduction in our standard of care treatment. So as you all know, the standard of care is 70 gray of chemoradiotherapy for these patients. And so we posited we could reduce the dose down to 3 weeks of treatment, or 30 gray. This is the work of a large team of people. Of course, this is a close collaboration with my long-term partner in crime, Nancy Lee, and included a broad range of medical oncologists, radiologists, physicists, cancer biologists, and of course, experts in immunogenomics and pathology to bring this together. And so I'm going to just discuss this entire group's work. And so I think, as many people in the room know, HPV-related head and neck cancers have an excellent prognosis compared to our HPV-negative tumors. The 5-year rates of overall survival are in the order of 80 to 90%. And the rates of local control are significantly higher than in HPV-negative tumors. This is our own data from Sloan Kettering showing rates of local regional failure on the order of low single digits in patients with oropharyngeal cancers. And this is in contrast to HPV-negative cancers, which typically have local failure rates of around 25%. Now, the field has obviously tried multiple strategies for de-escalating these patients, including omitting cisplatin, reducing radiation therapy dose by 10 gray, trying to give induction chemotherapy to identify patients who are sensitive to treatment, or using surgically based approaches to de-escalate therapy. Now, all of these paradigms fundamentally are trials that could have been designed in the 1970s. They're not really meant to personalize treatment to an individual patient's cancer. And unfortunately, what we've discovered is that de-escalating treatment for these patients is going to be a little harder than we thought, which I'll briefly review. Whoops, sorry. And so, as you guys know, the de-escalation based on trying to remove cisplatin has failed. Both 1016 and de-escalate were both negative studies, suggesting that we can't really safely de-escalate all head and neck cancer patients. And so, this idea that it was safe to de-escalate all patients, there was preclinical data suggesting that this is unlikely to be the case. So this is work from Randy Kimple at Wisconsin, looking at a panel of HPV positive cell lines and showing that there's actually significant heterogeneity, at least in vitro, in terms of radiotherapy sensitivity. There are some cell lines that are quite sensitive to radiation, while there are a number that are not. And these cell lines here, you might say, behave a little bit more like HPV negative cancers. We've actually, Randy's group and others have sort of suggested that part of the sensitivity is mediated by a defect in the DNA repair. Here you can see gamma H2X foci in these cell lines post-radiation. A higher level of foci means increasing sensitivity to radiotherapy. And you can see there's some HPV positive cell lines that have significantly increased amounts of damage after radiation, while there are a couple of lines that behave more like HPV negative tumors, again, suggesting that there is heterogeneity even within HPV related cancers. And so Nancy had developed an approach using on-treatment imaging to try and identify patients who may be having rapid responses to treatment. And so she did this using functional imaging with hypoxia tracer, which has been in the clinic for a long time, F-MISO, and evaluating what the response on F-MISO is during treatment, during 2 weeks into treatment. And using this approach, she had identified that it was safe to de-escalate patients to 60 gray, obtaining 100% local regional control at 3 years. And so what we were interested in was seeing if we could push, how far we could push the envelope on this. Could we actually go much lower than 60 gray? And so we had hypothesized that perhaps 30 gray would be sufficient to cure a large number of these patients. And where does that number come from? Well, that again comes from historical experiences again. So we know actually from another HPV-related cancer, anal cancers, that a pivotal study done by Norman Nigro actually demonstrated that giving 30 gray of radiotherapy with a concurrent cross-linking agent actually led to an over 85% complete pathologic response rate. Similarly, older data from Carlos Perez in the HPV negative area even demonstrated that giving 30 gray of radiotherapy alone neoadjuvantly led to a significant complete response rate pathologically. And so we hypothesized that this would also be true for HPV-related head and neck cancers. And we have learned from our clinical experience over the past couple of decades that IR plus a cross-linking agent like cisplatin actually synergize quite well. And we believe that's partially because these target two separate double-strand break repair pathways, subsequently leading to a synergistic effect in terms of DNA damage. And so we designed a pilot study to test if we could radically de-escalate therapy by a 60% order of magnitude. And the way this pilot study was conducted was we had all patients first undergo robotic resection at the primary site. Then they subsequently obtained a pre-treatment F-MISO scan. They were treated for 2 weeks with chemoradiotherapy with cisplatin. And they subsequently went an intra-treatment response assessment. Patients who were negative at this intra-treatment time point received a total dose of 30 gray. Those who were not negative or those who were positive went on to receive standard of care. So here we did a 60% reduction in our treatment to what would be considered treatment for lymphomas. Because this was the first time we were trying such a radical treatment, we had every patient go to neck dissection, and we wanted to see what pathologic response rates would be. And so we then did pathologic assessments. And so this is the cohort of 19 patients we wound up enrolling. The majority of patients were tonsil patients. They were relatively early stage. What I'm showing you here is AJCC 7th edition staging. So T1, T2, N1 to N2B. Mostly stage 4A in the old staging system. And of the 19 patients we wound up enrolling, 6 patients were negative on their functional imaging at baseline. And so those were automatically candidates for de-escalated based therapy. 13 of these patients were positive on their initial scans. And so they had a repeat scan. Of these, 9 had resolution of hypoxia during treatment. And so a total of 15 patients were candidates ultimately for de-escalated based therapy. There was 1 patient who came off study because they were hospitalized at an outside facility. And so this person plus the 3 who did not have resolution received standard chemoradiotherapy of 70 gray. All patients were monitored with intra-treatment or weekly MRIs and then subsequently monthly MRIs post completion of chemoradiotherapy. And so this is an example of 1 patient who went through treatment on 30 gray. So this is a patient who had hypoxia present on their baseline scan. They started treatment. And here you can see left-sided level 2 jugular digastric node. You can see there's a little area of fluid on a T2 image that's hyper intense. And we started treatment, and you can see that this lymph node is sort of remaining roughly the same during treatment. On week 3, actually, if you physically measured it or you felt it in the patient's neck, then the lymph node was actually a little bit larger. But if you look on the T2 image, you can actually see it's hyper intense, suggesting it's becoming more cystic. And so the intra-treatment scan for this patient actually showed resolution of hypoxia. And so the beam was actually shut off right here, even though while we were palpating this patient's neck, his lymph node had actually gotten larger. And so we shut the beam off, and then we wound up observing the patient very carefully for the next 4 months before his neck dissection. And here's what you can see happens post-treatment. So you can see that there's actually gradual, slow resolution. Here's 1 month post-treatment. You can see that the lymph nodes actually started shrinking. And 3 months post-treatment, you can see almost complete response, at least on MR-based imaging. When this patient went to neck dissection, he had no evidence of residual cancer. But what this really demonstrates, of course, and what many of us have known is, of course, is that the response to radiotherapy is protracted and takes several months to fully manifest. So what were the results? So for those of you who treat head and neck cancer in clinic, you know what happens to patients 3 weeks into treatment. And 3 weeks into treatment is when patients just start experiencing side effects from treatment. That's just when they start noticing taste changes. That's when they just start having sores develop in their mouth. And so this is what most of the patients who had 30 gray look like. They had very little evidence of any mucositis in their mouth. And of course, this is, a bad case of a 70 gray patient who had significant mucositis develop. But not surprisingly, we had no grade 3 mucositis, dysphagia, or dermatitis develop on any patient during treatment. And for those of you, as I was mentioning, who treat head and neck cancer, this is basically what happened. So I don't need to convince you of that. Similarly, because we shut the beam off at 3 weeks, the weight loss difference between the 3-week and the 7-week program is dramatically different. Most of our patients lost between 5 to 8 pounds, whereas typically we see a weight loss between 25 to 30 pounds. So we had a significant acute toxicity reduction. So with a median follow-up of 34 months, the 2-year overall survival and local control for the entire cohort was 95 and 94%. And 11 out of 15 patients had a complete pathologic response, with we believe 13 out of 15 patients having a major pathologic response. There was one patient who we believe had significant amounts of residual disease, who I'll go over in just a moment. So these are examples of the 2 cases we marked as non-complete pathologic responses, but we're considering major pathologic responses, and this is just for illustrative purposes. So Nora, our study pathologist, was very diligent in looking for scant tumor cells. And so here she's pointed them out for us, that there are a couple of abnormal appearing tumor cells that haven't completely disappeared. This is another example, again, of a couple of abnormal cells that are appearing in a much broader background of fibrosis and immune infiltrate. Now, what about the case that I mentioned to you that didn't have we believe did have bona fide residual disease? Well, this is an example of one patient where we were monitoring them with our MRIs. And here you can see that level 2 jugular digastric node. During treatment, this is week 1, this is week 2, this is post-treatment week 1. This is 6 weeks post-treatment. You can see there's further regression. But if you look carefully at the scan that's about 2 months post-treatment, you can see that that there's been some regrowth. And so when we observe this, we had the patient come back to clinic for a neck dissection. And the pathology at that neck dissection is going to look markedly different than what I showed you previously, because here you can clearly see large nests of viable tumor cell, although you see significant background of fibrosis and inflammation. At 20x, you can clearly see that there's still residual viable cancer, which is in marked distinction to the pathology I'd just shown you previously. So we do think that this one patient did have regrowth during treatment and bona fide residual disease. Now, what do we think was mediating this sensitivity? And so we think there are a couple of reasons why HPV-related cancers may be more sensitive to chemoradiotherapy. I highlighted to you work from Randy and others suggesting that there's a DNA repair defect in HPV-related cancers. We actually know that E7 can actually inhibit non-homologous end joining through its either interaction with RB or through its direct interaction with RNF168, which is a key regulator of non-homologous end joining. It's also been proposed that HPV may have an indirect effect on homologous recombination, although we ourselves think this is a little less likely. People have also speculated that there may be an increased immune response in these virally related cancers. And then, of course, we believe that hypoxia may be differentially affecting these malignancies. But our initial hypothesis is really based on the fact that we were using hypoxia imaging to identify patients who are having a rapid response, and that what was mediating this change in the microenvironment was actually coming from tumor sensitivity based on this underlying DNA repair defect. And so we're interested in trying to see if we can measure this actually in our patients. And so the way we approached this was with a computational tool based on mutational signatures. I think for those of you who aren't familiar with this, I think all of us know that cancers acquire a wide range of passenger mutations as they evolve. And it can take a couple of decades from the initial oncogenic event to a full frank malignancy to develop. And so as these passenger mutations are evolving, the pattern in these passenger mutations, this actually serves as an archaeologic history of the carcinogen exposure a cancer's had, or whether a specific DNA repair defect has occurred in that cancer. And so you can use the pattern in these mutations to identify if there's a DNA repair defect present in a specific malignancy. And so one classical example of this, which I think all the clinicians in the room are going to know, is, of course, microsatellite instability. This is something we've been testing in the clinic for a long time. This is an example of a microsatellite. This is the classical big A tract. Oops. This is the classical big A tract. And here you can see there's a deletion in this microsatellite. So microsatellite, to remind you, is a base that's repeated a number of times. So this is an adenosine that's repeated 26 times. And in the germline, you can see that this particular patient has two specific alleles with a deletion that's roughly 4 bases, and then another deletion that's roughly 2 bases compared to the reference. But in their tumor, this microsatellite has changed in size. The deletion compared to the reference has actually now increased. And so you can look at a number of these sites in the genome, these microsatellites, and you can determine if a tumor has microsatellite instability or defect in mismatch repair. We've been testing this clinically with the Bethesda panel for over 2 decades, right? You guys, everybody knows about the 5 PCR probes we can use to detect this, but NGS has allowed us to look at mutational signatures in much more detail. And so, for instance, we ourselves have looked at mutational signatures of homologous recombination deficiency, and we've shown that we can identify that homologous recombination deficiency can be a pan-cancer phenotype by looking for biallelic alterations in HR genes. We can identify that when you have it, even in a non-canonical cancer type, you see elevations in the mutational signatures associated with that, such as signature 3 or large-scale state transitions. I'd shown you the signature for mismatch repair. We ourselves have shown that when you have mismatch repair deficiencies in non-canonical cancer types, like head and neck cancer, you see elevated immune infiltrate. And I think, as everybody on the call knows, Luis Diaz and others, of course, have shown that you can use mismatch repair as a pan-cancer phenotype for immune checkpoint blockade treatments. So how is this relevant to HPV-related head and neck cancers? Well, we'll get to that in just a second. And one more background slide before that. And so, you know, we know there's preclinical data suggesting HPV hijacks the DNA damage response. And we were specifically interested in double-strand break repair pathways. Just to remind everyone, there are 2 main double-strand break repair pathways, and then there are a couple of backup repair pathways. I think everyone's familiar with non-homologous end joining, which is the main double-strand break repair pathway in G0 and G1. And then, of course, we all know about homologous recombination, which repairs a significant amount of the breaks in S and G2. There are backup repair pathways, single-stranded annealing. And of course, alternative end joining or templated mediated end joining. Templated mediating end joining winds up leading to deletions with microhomology at the breakpoints. And this backup repair pathway is activated when either non-homologous end joining is disabled or homologous recombination is disabled. And so the way this backup repair pathway works is it uses microhomology at the breakpoints to ligate the double-strand break. And we can actually look for deletions that have microhomology at the breakpoints to determine that these double-strand breaks were repaired by this backup repair pathway. And so the reason this repair pathway is interesting is actually whole genome data from PCOG, which was initially released in 2019, published in Nature last year, demonstrated that actually HPV-related head and neck cancers have these deletions of the microhomology occur, suggesting that one of these double-strand break repair pathways is defective in HPV-related head and neck cancers. And collaborators of ours, Jonathan Lehman, Simon Powell, and Dan Higginson had shown using reporter assays where we've transfected U2OS cells with the various HPV viral oncogenes, that E7 actually leads to increased activity in alternative end joining, suggesting that leads to increased activity in alternative end joining and a decrease in activity in non-homologous end joining. So as you recall, non-homologous end joining is the major double-strand break repair pathway in G0 and G1, and E7, it appears, disables this in the reporter system and leads to complementary activation in a backup repair pathway, suggesting that some HPV-related cancers are disabling this pathway. So what we wound up to look for this mutational signature, we need to actually wind up sequencing a broad swath of the cancer genome to be able to evaluate this fully. So our in-house panel or targeted sequencing approach, MSK Impact, sequences about 1 megabase of the genome. Now, to look at deletions, 1 megabase of the genome is not enough because basically the frequency of deletions is about 1/10 the frequency of mutations. So for those of you who look at targeted sequencing data, you know when you sequence head and neck cancers with a targeted panel, you usually identify only a couple of mutations. So you would identify no deletions. Now, if you use whole exome data, you get 36 megabases of the genome. And a head and neck cancer will typically have several dozen mutations. That means there will only be 1, 2, or 3 deletions picked up from exome sequencing, which again is not really enough to look for mutational signatures for deletion. So we wound up doing whole genome sequencing, which is of course 2 orders of magnitude larger than whole exome. And here you wind up with thousands of mutations and usually dozens to hundreds of deletions, which allow you to reliably look for mutational signatures based on deletions. And so this is an example of the number of deletions you see from either whole genomes or exomes. And so you can see on average, we had about 60 deletions in our cohort, and the exome data usually wind up with just only a couple of deletions detected, which is not enough for mutational signatures. And so we performed whole genome sequencing on the patients who underwent 30 Gray. And we did not identify a single gene mutation that was associated with the response to treatment, nor did the classical single base substitution patterns really associate with response. Those would be things like APOBEC or smoking signature. However, when we looked at deletions with microhomology, which again indicated double-strand break repair defect, we found that patients who were eligible for 30 Gray or who had a major pathologic response to 30 Gray had an increase in this signature, suggesting they had a more profound defect in this pathway. We validated this work by looking at another study from Mayo Clinic, which wasn't as bold as the study we had conducted. This was using 30 Gray post-operatively instead of definitively. But we similarly identified using whole genome sequencing from Mayo Clinic data that patients who responded post-operatively had a higher evidence of this signature being present. Again, suggesting that a subset of HPV-related cancers have this double-strand break repair pathway defect. Now, I know some of you might be thinking, you know, we performed surgery post-treatment. And if we hadn't performed the surgery, the cancer would have grown back in each of these cases. So I can tell you 100% confidently that's not the case, because we've actually enrolled over now 200 patients on subsequent studies. We finished one cohort where we enrolled 158 patients where we observed them, and we've gone on to now in our second generation study, and we're now actually in our third generation study where we've enrolled another 60 patients. And so in this study, we've now, in our second generation study, nobody gets a neck dissection basically. And so we presented some of the early work from this study at ASCO just a few weeks ago. Here is our 1-year local regional control rates without planned surgery. And that's 94% in about 128 patients that underwent 30 gray without that surgery happening. Our 1-year distant metastasis free and overall survival rate was 100% in the patients who were de-escalated to 30 gray, suggesting that we are dramatically overtreating a wide variety, the vast majority of patients we're seeing in our clinical practice to date. And so what I want to leave you with is that even within histology, tumors have markedly differing radiosensitivities. And we have very strong evidence now, I would say, that in HPV positive head and neck cancer, there are a subset of patients that can be dramatically de-escalated. There are a subset that we can cure with 30 gray, and there are a subset that we know needs 70 gray based on the results of de-escalate and RTOG 1016. And the job for us as scientists in this space is to make this robust. We believe that the on-treatment imaging approach we're taking is one way of doing this, but we don't think this is limited to HPV positive head and neck cancers. We would be bold enough to say that this is true probably for every disease we're treating with radiation oncology. We're effectively, to be blunt, we're performing Halsted mastectomies on patients we're seeing in clinic every day, when the vast majority of our patients would be cured with something like a lumpectomy, or in radiation oncology terms, we're giving 70 to people who really only need 30. And our job is really to now start figuring out how we can identify those patients safely. So with that, I want to shift gears and discuss a second story, which is related to mutation-based personalization of radiotherapy dose. So we know that there are multiple factors that mediate radiation response, including tumor bulk, histology, the microenvironment we had reviewed using hypoxia, and of course, there's intrinsic markers of radiation sensitivity. So I'm going to talk about an intrinsic marker of radiation sensitivity that's genetic based, but of course, there are other things that mediate radiation sensitivity. I'm going to skip this for just the sake of time. And so I just want to remind everyone, when you look at NGS data, it's important that not all mutations are equivalent to each other. So some mutations actually knock out the function in a gene. Some mutations, if you're looking at an oncogene, actually activate the function of a gene. And so it's important to differentiate these two. So I'm going to discuss a significant amount about loss of function mutations. And you can just think of these as mutations that completely inhibit the function of a gene. Those are very different than missense mutations, which are the most common mutations we actually see when we do sequencing. And so we've long known that P53 mutations are, of course, associated with prognosis in head and neck cancers. This is data from Poeta and colleagues, the Hopkins and MD Anderson group, showing that P53 mutations are prognostic of outcome in patients who have surgery or surgery plus radiotherapy. And the Cancer Genome Atlas has really identified, or the TCGA project has really identified the pathways that are altered in cancer in general. Now, when we look at many of these pathways, it's sometimes hard to think about how these pathways would wind up modulating radiation sensitivity. And so, but we think there are a few areas that are very easy, low-hanging fruit to investigate. I'm going to tell you one of those today. And so, not surprisingly, we think DNA repair pathways, of course, are one of those low-hanging fruits. And we know repair pathways are actually altered in cancer. We discussed mismatch repair being altered in cancer. I briefly told you about homologous recombination being altered in cancer, but there are a number of other repair pathways that are also altered in cancer. And we know these are altered in cancer because they're germline predisposition syndromes that lead to cancer predisposition when these pathways are altered. And so this is our look at the most, probably the easiest pathway that I think everyone would believe was associated with response to radiotherapy, which is looking at what happens when you look for mutations in non-homologous end joining genes. And so you can see that there's actually a moderate frequency of mutations in non-homologous end joining genes across cancer types. Now, this is looking also at missense mutations or non-synonymous mutations. And what we really want to focus on is loss of function mutations, which are going to be functional. But even when you just focus on the functional mutations, there's a minority of patients that have actually altering mutations in non-homologous end joining genes in cancer. And so what really got us latched onto this was actually a patient we saw in clinic. And so this was a 93-year-old with oral cavity cancer who had an unresectable cancer, who we thought had 6 months to live. We gave her quad shot radiotherapy. And remarkably, she had a complete metabolic response. And she's now actually 100 years old without any evidence of disease. So when we sequenced her tumor, we identified a mutation in ATM. And so everybody who's in radiation oncology, of course, knows about ataxia telangiectasia, the hereditary syndrome associated with exquisite germline sensitivity to radiotherapy. But here we had identified a somatic mutation was associated with exquisite tumor sensitivity to radiotherapy. And so because I think all of you know about ataxia telangiectasia, I'm going to just skip this for the sake of time. Somatic mutations in ataxia telangiectasia occur not infrequently across cancer types. And so this is something that we believe is therapeutically exploitable. And so we've recently reported our results looking at several hundred patients who we treated with palliative doses of radiotherapy. So this is a cohort now of 350 patients where we evaluated responses to radiotherapy between those missense mutations and pathogenic mutations in ATM. And there were no significant differences in baseline clinical characteristics. This was a pan-cancer analysis. So we did group patients who had differing histologies, including lung, breast, prostate, colorectal, and endometrial cancers, but there was no broad imbalances in cancer subtype. This was, again, pan-cancer, and so we looked at a broad range of doses that these patients were treated with, but again, there was no sort of broad imbalance in the classical things we would associate with response, including mean radiation dose here, shown in biological effective doses, or sizes of tumors that were irradiated. And so what we found was that actually having a pathogenic mutation in ATM led to a 50% reduction in local failure when you receive palliative doses of radiotherapy. So again, those missense mutations are genes that we don't think would have an effect on radiation response. This black line, which is mutations in FAT1, is another mutation looking at another control group where we looked at patients who have a mutation in another large gene. These are sort of the cancer sub-specific data from that paper. So when you look just within individual cancer subtypes, you see, again, very similar results, that even within individual cancer subtypes, patients who have a loss of function mutation in ATM have significantly improved local control to low doses of palliative radiotherapy. We don't believe this is prognostic. Not surprisingly, radiating one site in somebody who has widely metastatic disease is not going to wind up improving local control, even if that one site has better local control. This on multivariate analysis, this remained significant. This wasn't confounded by TP53 genotype, wasn't confounded by dose, wasn't confounded by cancer subtype. Perhaps not surprisingly, though, of course, when radiotherapy was given to gross disease, not surprisingly, gross disease did come out significant in multivariate analysis. Most intriguingly, which I think is very important, and I think many of us know, single allele alterations in ATM, although they sensitize, we think they have a modest radiosensitizing effect. There are a subset of patients that have both copies of the gene that have complete knockout of ATM. And those patients had a remarkably further improvement in local control. There were only a couple of actual failures long-term in the patients with biallelic alterations. So From this story, I want to leave with that, loss of function mutations in ATM, germline or somatic, are associated with increased sensitivity to radiotherapy and significantly reduced rates of local regional failure, especially when you have a biallelic alteration in ATM. Now, how can we move forward in terms of making or personalizing radiotherapy regimens for individual patients? And what are we doing at Sloan Kettering right now beyond the stories I've shown you? So we're trying to prospectively validate some of the work I've shown you for ATM. So we've launched a study in bone metastasis where we're significantly reducing the dose in ATM carriers to see if we can maintain excellent local control. We're of course interested in thinking about using basket studies for DDR defective tumors in lung cancer. And we've opened up actually sort of an interesting concept in pancreatic cancer where we're taking patients who have a DDR defect and we're going to wind up irradiating their entire liver, the most common site of metastasis in pancreatic cancer, to see if we can improve outcomes similar to what we do for PCI and small cell lung cancer. But we think there are actually many avenues beyond what I'm just showing you here. But as soon as we start uncovering the biology of radiation response, it really opens up a realm of possibilities on how we can start using radiotherapy more uniquely for individual patient tumors. What happens if we don't do this? So I didn't discuss this pathway in detail, but there's data for in bladder cancer for using mutations in ERCC2 have been associated with phenomenal responses to induction to chemotherapy, and specifically cisplatin. ERCC2 is a nucleotide excision repair gene. Nucleotide excision repair is a very important pathway for repairing intrastrand crosslinks. I'm going to skip this slide just for the sake of time. But what I want to remind everyone is that our colleagues in medical oncology are moving very ambitiously to start bringing this biologic data to the advanced setting. And so there are multiple cooperative group studies now exploring whether we can use ERCC2 mutations to treat people in a curative manner with chemotherapy alone. So while we are still stuck trying to figure out how to make small adjustments in radiotherapy, and many of my colleagues get very anxious about making small changes on biologic features or trying to design neoadjuvant studies in this space, our medical oncology colleagues in the cooperative group setting are running therapies based on genetic biomarkers and trying to cure patients with chemotherapy alone. So if we don't start moving into this space aggressively, our medical oncology colleagues will do it for us. And so with that, I'd like to lead with a summary of what I talked about today. I hope I've convinced you that a significant number of HPV positive cancers are curable with just 30 gray of chemoradiotherapy alone. We're treating the vast majority of them with 70 gray, and that's because we have not put in the effort to try and identify people who are sensitive. And our goal as a field is really to start doing that. We believe they can be identified with on-treatment imaging. We've identified that a mutational signature indicative of a defect in the DNA damage response may be associated with good outcome in those HPV positive head and neck cancers. In the second story I told you, I've demonstrated that mutations in DNA repair genes are common in cancer. And we believe that as radiation oncologists, we need to start taking advantage of those mutations and start personalizing our therapy based on that. And I've suggested to you several trials we have open at Sloan Kettering trying to take advantage of that. And then I want to leave you with, if we don't personalize our local regional treatments, our medical oncology colleagues will do it for us. And so the real question for us is, how do we start moving to trials in the next few years? With that, I'd like to acknowledge the large group of people who sort of contributed to the work I've presented. Nancy is my long-term partner in crime who we've worked on very closely on the de-escalation study. She's the clinical driver, I'm the translational driver. The DNA repair mutation work is doing close collaboration with my colleague Jeremy Seton and Tim and Simon. And then, of course, there's a broad team of physician scientists who help. I've worked. There are a couple of stories I didn't get to tell you guys today on IO, but hopefully for another time. And so with that, I'm happy to take any questions.
Great, thank you so much, Nadeem. A really fascinating talk. And as you alluded to, for anyone who's not so familiar with Nadeem's work, there's a huge body of it out there crossing multiple fields. So I'd strongly encourage you to go check out his other very impressive work as well. So yeah, please feel free to raise your hands or ask questions in the chat. And whilst you're doing that, maybe I'll kick off with a first one. So, so thinking about personalizing radiation dose, I think you've very nicely shown how this could be done very effectively in terms of de-escalating dose for patients whose tumors are sensitive. Have you got any thoughts about what to do about the other patients whose tumors are very resistant to treatment? And there's been a lot of work on dose escalation, which I think we've kind of reached the limits of in many cases. And yeah, so what are your thoughts about what to do up the other end of the spectrum?
Yeah, so I think that's very important concept to remember, is that we also want to help patients we're not curing. And so the de-escalation is a little bit easier because we have started to make, I think, a lot of headway in understanding response to radiotherapy. Understanding resistance to radiation, I think, has been a little bit more challenging. I think one big issue with the escalation studies we've conducted in general is, again, they've been non-personalized. So performing non-personalized escalation studies really assumes that we're going to have a gigantic effect. I think we can continue to, again, try using on-treatment imaging to identify patients who aren't having rapid responses. And that subset of patients is the patients we really need to think about escalation, whether that's with radiation or by flipping in what we're using to sensitize the radiation. So I really think to move the field forward in terms of escalating therapy, we really need to start identifying just the subsets of patients that we don't cure with our current regimens, or otherwise we are not going to be able to make substantial progress.
Great. And then one other question along similar lines is, do you think there's any scope for personalizing not only the total dose, but also the fractionation as well? So there've been lots of trials historically comparing different fractionation schedules, but again, broadly in unselected groups of patients. So do you think there are likely to be subsets of patients who respond better to different schedules?
Yeah, no, I think there's definitely a wide range of opportunities to even use personalizing treatment based on fractionation schedule. I think the key thing is we need to develop these early trial concepts to actually test that. And so I really like neoadjuvant study designs to try and test things very quickly to see if our underlying hypothesis is correct. And so I think in the field in general, instead of, we've focused on conducting very large phase 3 studies of very modest changes where we then get disappointed. And I think we as a field need to start moving into thinking about how can we use neoadjuvant based studies to much more rapidly test hypotheses and circulate through how can we change fractionation to modulate sensitivity in an individual patient basis.
Great. Does anyone else have any questions? Oh, sorry, Anna Wilkins has got her hand raised.
Yeah, thanks very much, Jamie, and thank you for such an interesting talk. And it's kind of triggered loads of questions, but just to simplify it in one, your talk is, and your strategy is very DNA repair centric, and you've obviously got superb data to back that up as a de-escalation strategy. But do you think there's scope to kind of bring in other environmental features into the de-escalate or escalate strategy? So, for example, I was involved in a neoadjuvant study in rectal cancer where the tumours with lots of cancer-associated fibroblast enrichment responded badly to radiation. And do you think there's scope for incorporating things like a clever AI measurement of more histological features? And if you do think that, how do you think we do it best?
So I know I focused a lot on DNA repair, but I don't want anybody to think I only think DNA repair is the only way to de-escalate. We actually do think the microenvironment is going to play a very important role in modulating radiation sensitivity. And we're very interested in sort of looking at the adaptive immune response. But I agree with you, looking at other components like the fibroblasts, or other stromal members of the microenvironment are unique ways of approaching this angle. And I think rectal cancer in some ways is a really good way of thinking about this, because rectal cancer, we do deliver treatment neoadjuvantly. And so, I think what you're suggesting about looking at AI-based approaches to look at the microenvironment and try and stratify patients is a great starting point. And then I think once we have that, we really need to think about how can we do an interventional study based on that information to really test that concept in a small number of patients.
Brilliant. Yeah, very interesting. Thanks so much. I agree.
Anyone else? If not, maybe I'll ask one final question, which is a bit of a broader one. So in like we're fortunate in the UK that one of the major funders, Cancer Research UK, has just started putting a lot more money into radiotherapy research, which is bringing in lots of people from other fields who haven't worked in radiotherapy in the past, which is very exciting. But I wonder if you could say a little bit about if you were to design how radiotherapy research was conducted in general without all the kind of the dogma that comes along with all the previous work, what would your advice be in terms of how we go about things if we're starting from a completely clean slate?
Yeah, you know, I mean, I think we've learned some very important principles from our prior work, but we've also learned a ton about cancer in the past couple of decades, and we really need to start thinking about how can we take what we've learned in cancer science in general, in both tumor genetics, the immune system, the microenvironment, and start marrying those advances with what we know about radiation. And so I think that, you know, we really need people outside of radiation oncology who are leaders in that space to help us translate that information into radiation oncology. And I think, you know, that what it sounds like what you guys are doing is the perfect thing, you know, bringing out outside expertise, and we need people at the interface to really marry those two groups together.
Great. Well, thanks a lot, and thanks so much again for giving us such a great talk. Thanks everyone for attending. I'd like to remind you that we have this seminar on roughly a monthly basis where we get top international speakers in to present their work. So thanks again for joining, and hopefully we'll see you at the next one.
Thanks, everybody.